In this video, we're going to review a few orthopedic disorders that you may see in the pediatric population. We're going to start with congenital hip dislocation. This is not uncommon. It can be due to a variety of reasons. This one you can see, now it looks kind of odd, but you have to remember that with kids, here's the epiphyseal plate, so it's not like this is the problem. This is the epiphysis, this is the head of the femur, but you can't see probably the rest of the head of the femur because it's still cartilaginous and still developing. But this, the child's left femur is into the acetabulum. The right femur, however, clearly is not in the acetabulum. So this right hip is the one that's dislocated. This can occur during development because the acetabulum fails to develop appropriately. It can occur it's not unusual to see it with kids who have multiple developmental problems who are pretty complicated because they just don't have, they have a lot of muscle imbalances that are pulling on the hips, and again, the acetabulum hasn't developed to create the stability. It can also occur during a birthing trauma, especially if you think about a breech presentation, which means coming out bottom end first. There's actually a sign that they'll do, and if any of you have had children and you've taken them in for well baby visits, you may remember the practitioner doing this. They lie the baby on their back, kind of almost up into a hook-lying position with both hands, and then they'll externally rotate and abduct the hip, and what they're trying to feel for is just a click, feeling the head of the femur clicking in and out of the acetabulum. So they're looking for instability. Other signs might be that the child just doesn't have adequate hip abduction range of motion, pretty evident when you're trying to change diapers. And if it's a little bit of an older child, you might see a Trendelenburg sign during gait. Other problems that can occur if the dislocation is going on for a while, if they can't do anything about it or change it, might create a hip flexion contracture or a scoliosis. There certainly can be avascular necrosis, where the head of the femur doesn't have adequate blood supply and will die, or a pelvic obliquity. So for treatment of this, if the child's very young, if it's an infant or younger, they will just put them in a full body abduction splint or cast or bracing, and basically they just seat in the flexion and abduction position that seats the head of the femur more deeply into the acetabulum and allows it to develop there. If the child is older, they may need surgery to possibly release some tight muscles, to improve the depth of that acetabulum, because if it's been dislocated for a while, for a couple of years, the acetabulum may never have developed. An older child, again, may need traction in addition to the surgery, and if it's a much older child, they may end up having a total hip replacement. So again, you may be seeing a child with multiple medical problems, complicated developmental delay issues, and they may not be aware. This may be a child who doesn't crawl, doesn't walk or stand until very, many years later in life, and so it may just be a problem that doesn't get identified, or that doesn't get addressed, or that develops later because their skeletal maturation just doesn't continue like it would if they were standing and weight bearing. So from a physical therapy standpoint, we definitely need to work on strengthening and stability around the pelvic girdle, particularly gluteus medius, as you can imagine, but also hip extensors, quadriceps, and even the hip flexors and knee flexors need to be looked at. Certainly, if the child is of ambulatory age, we would need to work on gait training or at least standing activities. The next one we're going to talk about is not really a condition, it's more of a disease. It's called Legg-Calve Perthes disease, and this is avascular necrosis of the femoral head, basically. It's a fancy name for that. And so on the right side here, here's the epiphysis, and here's the head of the femur. Again, it doesn't look very big, but you can tell from this space we're seeing the cartilaginous, we're seeing the ossified portion, but it's cartilaginous up here. But over here, it looks really different. So here's the epiphysis, but this looks all rough in here. And certainly this is very, very flattened. So this side, the left side in this case, is the problem. So they don't really know what causes it other than an interruption of the blood supply to the head of the femur. With most things that happen to kids, we always suspect a genetic link or predisposition. There's also some disruption apparently in skeletal maturity or a delay in skeletal development, again, usually for unknown reasons, but something hasn't quite proceeded correctly during lower extremity skeletal development. This tends to happen in kids that are a little bit older, not infants, but and past the time when they would be ambulating. So 4 to 8 years of age is the most typical time to see this develop. And so kids will complain of pain, not surprisingly. Remember that when we have hip problems, we generally don't feel the pain laterally, but more in the groin area. So kids complaining of groin pain. And again, an adduction contracture, because without the head of the femur, the ability to abduct would definitely be limited. So again, with this, they may ultimately need to do surgery. They would try non-weight bearing, maybe an abduction cast. Here's another picture, and it's kind of a close-up of the previous one, where you can certainly see the normal versus the avascular necrotic hip. So here's an example of the bracing that they may do with the abduction splint or abduction cast. So on the left, it's called a Petrie cast or brace, and again, it puts them into a wide bit of abduction to seat the head of the femur into the acetabulum. After surgery, they may put them into a spica cast, and that's what you're seeing on the far right. So spica, hip spica, is basically like wearing a plaster pair of pants. In this case, it's a unilateral spica, so they only have one plaster pant leg, but it goes up around the hips, up around the waist and lower trunk area to stabilize the entire hip. Again, from physical therapy standpoint, there may well be pain management issues that we're addressing because of the necrosis. Certainly strengthening of the hip abductors, hip extensors. Also, we may need to work on range of motion if they've developed a hip adduction contracture, internal rotation contracture of the hip, and of course gait training as well. This is an example of a brace that allows some ambulation. It's kind of a articulated brace. It's called a Scotch-Rite brace, and again, it stabilizes the hip and seats the head of the femur into the acetabulum and allows some gait and some ambulation. The last disorder we're going to talk about is clubfoot, or talipes equinovarus. So talipes, the talus, and then equinovarus is plantar flexion and a varus deformity. So that's pretty much what that looks like. And this is not an unusual condition. Kids with no other problems at all can be born with club feet, or it can also accompany other developmental disorders. Spina bifida is one we're going to talk about with the neurological problems of the pediatrics. A variety of other developmental conditions may result in this. So again, the foot's in plantar flexion and you can tell very inverted, varus deformity with a high arch, and definitely needs surgical correction. So they would surgically correct it and generally do bracing after that, which would definitely need to be followed by physical therapy. And we would often follow that up with either taping or serial casting, stretching, standing, weight bearing, gait training, whatever. Kind of depends on the age of the child, how much standing and weight bearing they're able to do, but definitely needing to reposition them, and ultimately they may need gait training later at the point where it would be appropriate in their age cycle. So this is an example of just the reorientation, so they never quite get rid of that varus posture or the kind of supinated posture of the foot. So you can see in the before picture, I mean, it's well turned in and clearly that's taken care of. But when you look even at the after picture, the heel is planted, but you can definitely get a sense that there's a lot of kind of pressure along the lateral border of the foot, and you definitely get a sense of that supinated posture even in a weight-bearing position.